Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey everyone, welcome back to the Wild Health Podcast. This is Dr. Carl Seger, physician at Wild Health. Today I have Dr. Julie Siemers, who is originally a registered nurse and then got her master's in nursing and then her doctorate in nursing. So a lot of schooling. And she's a patient safety consult and a nurse leader, nurse educator, and founder of Life Beat Solutions, and she's also a best-selling author about surviving your hospital stay, and holds a doctorate in nursing, like I said, from where's this at in Nevada?
Royal University is in Las Vegas area.
Oh, it's
Yeah.
in Vegas. Okay, yeah.
Mhm.
So Julie has 40 years of healthcare experience in ICUs and emergency departments and doing trauma care, and so that's we brought her on here to talk about what do you do if you do get into the hospital, and how do you take care of yourself? At Wild Health, we're trying to preventative medicine as much as we can, but we realize things happen. And to a lot of our patients, I actually have a patient today who's a dear patient of mine who's in a hospital getting a procedure today. And so I think about this a lot. And my background is I was before in Wild Health, I was an emergency medicine physician for 15 years and was at critical access hospitals, but also university settings and teaching. And so this is really important to us. This is probably how we got into Wild Health and preventative medicine, is because of the current system that exists. So welcome, Julie. It's really nice to have you here.
Thank you. Appreciate you having me on as a guest.
Yeah, no, this is great. So I have a bunch of questions about this, and some of them, sometimes I ask questions that are unknowable. So so don't be worried about that. But you've worked in hospitals for decades. So I mean, just to kick it off, like, what do you think the scariest or most frustrating thing you've seen is for patient care?
Well, communication is a huge problem that contributes to patient harm. The Joint Commission tells us about 70% of patient harm events are due to communication breakdowns, whether it's between the healthcare team or healthcare team and the patient and the family themselves. So I think that's an immediate fix that we could implement as soon as we help people become aware of what that is. A lot of people don't want to speak up and are afraid to speak up because we still live in a culture, I think, of the doctor knows best. But in our current healthcare system, it's kind of crazy. We have to speak up and communicate with each other.
Yeah, so I mean, this is funny because people always assume, like, if you're in a hospital, it's like a safe place to be. Yeah, I don't know if everybody assumes that, but I think a lot of people do. And obviously mistakes happen. What do you think I guess, say one thing or two things that you think you wish every patient knew before they go in and they have to be admitted to a hospital, either for a procedure, something voluntary or something involuntary?
I think one of the first things I do now that I learned this, and I was a nurse 30 years before I started exploring into and researching for my doctoral degree into the patient safety realm. I had no idea, but there's a website, a free website that's nonprofit called the Leapfrog Group, but the website is hospitalsafetygrade.org. And hospitals are rated on 22 categories and subcategories of safety. You can go in and put your zip code and find out if your hospital that you want to go to or that your doctor is suggesting you go to for surgery or whatever, if it's rated an A, B, C, D, or F. Personally, I would never ever go to a D or F rated hospital if I had the choice. Their outcomes, I believe it was if you go to a D rated hospital versus an A, your chance of harm or dying was 92% higher.
Wow.
So that's the first place I'd start.
That's a big number.
It is.
Okay. Okay. Well, I guess, what are the metrics they're following there, that they're rating that on the safety? Because safety is like, I mean, that's a broad term. Do you know what metrics they're kinda using?
Yeah, for overall safety, for infections, they have categories that rate, and this is all based on CMS data as well.
Okay.
So it's not subjective, it's objective data. The infection rates for MRSA, for C. difficile, for those kinds of things. Surgical outcomes, how many patients postoperatively develop blood clots that is preventable? How many patients develop respiratory problems such as pneumonia post-op, which much of that is preventable too. So that's what I would be doing as a patient is asking your surgeon if you're going to a hospital with low rated areas in those categories that you can say, what are you going to do to help make sure my mom who's having surgery doesn't get a blood clot? What are the protocols and policies that you write?
So, do you think this is always like, I think maybe what a lot of patients assume, and is that if they ask questions, they're going to annoy their care team and that they'll end up getting worse care because of that.
I've heard that, yes. Um, what I believe is we've got to change the culture. And by changing the culture to develop that bridge of communication, we have to speak up. We have to ask questions. So, one of the tips I give patients and their families is the three Ps: be present, be polite, but be persistent. Especially if you think something is wrong with your family member, like, my mom isn't acting right. This is not like her. And the nurse or doctor may not understand that's not the norm for this patient. And so, again, working together and communicating with each other. Hmm, is this new for your mom? She doesn't act like this. So let's figure out what's going on.
So I'm interested in this because I've I've seen this, and, like, my wife and I are both physicians. We had a daughter who was quite ill over the last couple of years, and it's kind of been staggering to us, like, how difficult it is to advocate for whoever you're there with. And, I'm sure it is even more difficult. I'm sure there's data around advocating for someone else versus yourself. In fact, I know there is, but I I think my question for you is, how do you think we change the culture? Because, like, if my wife and I are struggling to advocate and we're both physicians, like, that's one thing my wife and I kept saying to ourselves, like, what do people do who don't have, extensive medical
The
knowledge
background.
and don't have the
Hmm.
background, but also, like, here's people we're supposed to be colleagues with, and you're like, "Hey, what are you doing there?" Kinda thing. So, how do we change this culture as a society?
Well, the first thing I tell people is you have to become informed as best they can. They don't need a nursing degree or a medical degree, but need to learn about their own medications or their family's medications, their own disease processes. And of course, as you guys talk about on your show, preventing disease is the proactive way to be, right? But our society is pretty sick with chronic disease. We know that. So it really is learning as much as you can and speaking up. So I shared this on my TEDx talk that just came out last month. It's the cuss words. Is I'm concerned, uncomfortable, scared, and there's a safety issue. So if we can use those operative words when we're trying to communicate with the healthcare team appropriately,
Yeah.
I'm really concerned. My husband's breathing is really scaring me.
Hmm.
And those should be able to operationalize the team to say, let's check. But again, in the hurry, scurry, flurry, a lot of times that
Mm.
doesn't happen, right?
Yeah, I think that's really, I like the cuss words. I mean, I like cuss words, but specifically, though, that what you just said. Um, okay. So what do you think? So if you're admitted to the hospital, you didn't have a choice in where you went, or maybe you did, you educated yourself. What's the first thing you should do to sort of try to keep yourself safe?
Well, understanding a few basics, and that's why I wrote my book that came out last year to help patients and their families understanding the basics of vital signs. Like nobody's heart rate should be over 100 for sustained period of time. And a lot of times there's monitors in the room where you can check the pulse, the heart rate yourself when you're concerned or ask the nurse, can you please check my, dad's respiratory rate? It seems higher than it was. And just understanding those physiological changes that occur, it's documented in the literature that before a patient goes into an unplanned cardiac arrest or deteriorates and becomes unstable, those physiological signs happen 6 to 24 hours prior to the unplanned cardiac arrest. So they give us clues. Our body gives us clues as we're becoming unstable. And so I think of the family members as the extra eyes and ears that can really help the healthcare team if we just will listen.
Yeah, that's what so I can't quote this data off myself, but I know that a patient a patient by him or herself is way less safe than somebody who has somebody at the bedside.
Yes.
You probably know that data off the top of your head. That's not something I work with.
You know, I don't know the statistics, but what I can tell you is that the stories I hear from so many people are if I weren't there, I don't know that my mom would be alive. And again, it's just that extra set of ears and eyes again to help because the patients have nuances that we as just the nurse or doctor coming in the room and seeing them for the first time we're taking care of them for one day we just don't know, but the family does, and those nuances can be significant.
Yeah, what do you I think I mean, I definitely tell people this is one of the things I'm interested in. Maybe this in your book. But how much weight are you putting to that on an individual patient of having an advocate there for them?
I think it's huge. I really do. Because the other thing the advocate can do is take notes. Again, communication crossing or misfiring, miscrossing can be huge. And I know that when patients' family members take notes, and again, this isn't to um, do anything litigious most of the time. It is really just to say, hey, well, the other doctor, because we have,
Yeah.
nephrologist,
Yeah.
cardiologist, whatever, the other doctor said this and that's conflicting with what you're saying. Help us understand the best route or what we are supposed to do. Or that doctor ordered a blood thinner. Does my mom really need two of them? That could be dangerous, right? And again, oh, I didn't realize, sometimes the communication can really present opportunities for patient harm.
Yeah, I mean, the number I have in my head is at least it was around medication errors, where there's like a 60% or so reduction in medication errors when an advocate is at the bedside. Because an advocate will say like, "Oh, what's the med we're given?" And then if you're paying attention, you're like, "Wait, that's not the medication we talked about." And a 60% reduction is pretty massive, but
It
that's the
is.
number I have in my head, but I don't have the numbers in my head for, like, procedural, data, but, well, that's great. When so is there a certain this is something that we talked about, in when I used to work at a university, um, was when is the time of period of the year or, even the day of the week where it's the worst time or the best time to go to a hospital? So, for example, like, should I avoid surgery on a Friday? Or the common thing that was discussed is, should you go to a university hospital in July when all the residents have just changed over? Um, and there was an argument that, that if, you it was actually better to go in July or August than it was in June, because June is when all the residents are getting ready to be done, and they're kinda burnt out, and they're moving on to the next thing, and then July and August, the new residents that are coming in are just upgraded, are super vigilant. and really paying attention. But then there's also the argument, well, if you go in July, you got a first year resident who's taking care of you. That also seems like a bad plan. None of these plans seem good. Uh, but
Yeah, I do know the studies that I've read, nights, weekends, and holidays
mm,
makes sense, right? There is less staff. There is um, a lot of on-call physicians covering for the primary physician. And I'll give you a case example of that happened. A man had knee surgery, ended up with compartment syndrome, but it wasn't recognized, unfortunately, until it was too late. But a nurse is calling the on-call physician and saying, "Hey, his foot's cool. He's complaining of excessive pain in that leg."
yeah,
And the on-call person said, "It's been that way since before surgery. Don't worry about it." And the nurse took him at his word,
sure.
unfortunately. But when they came in the next morning, he unfortunately lost his leg because it had
Mm,
been so long that the circulation had been compromised.
yeah,
So,
yeah.
that's one of the risks of not knowing the patients that well during nights, weekends, and holidays.
Yeah, that's like, that tale we used told is kind of tale as old as time. And compartment syndrome, for those who don't know, is like you have a certain compartments of muscle compartments in your leg, and if you get too much swelling from bleeding or other just inflammation, you can you stop the blood supply and the nerve supply to your lower part of your leg, and people lose their leg over this. It's a I would say it's a common malpractice claim, but it's something dreaded and feared as it should be. Um, yeah, so yeah, the nights, weekends, holidays, um, and then I think do you know any data around the university hospital? Uh,
I don't,
yeah, okay.
but I worked there at University Medical Center in Las Vegas. That was where the trauma center was, and
Yeah,
I was a flight nurse there. And yeah, there's a big difference in the residents' knowledge and not just productivity, but safety,
mm,
really.
yeah,
And they want to use what they've learned, which is the whole purpose of doing a residency, right?
right.
But when you've got a resident in the trauma center saying, put down a nasogastric tube on this patient that's got a suspected basilar skull fracture, like, sir, would you like to rethink that?
Yeah. Well, that's
So,
where, like, nursing becomes such a big deal and, like, their ability and like you said, so it's a communication thing. So if, uh, this has gotten way better even since, when I was a medical student at the University of Washington all the way to residency and now, like, communication around that, like, um in the hierarchy of medicine has definitely gotten better. I mean, whereas nurses feel more comfortable and emboldened and empowered because of, say, books like yours, um, but also just initiatives across hospital systems to say, hey, everyone should be able to speak up. So timeouts before procedures and saying, making sure we're all on the same page and everybody having equal holding in the hospital and the safety of the patient. So empowering the janitor to speak up if they see something that's weird going on is in all the way the whole staff. So everybody's willing to do that. It's much better than it used to be, as far as from a communication standpoint, but there's still like you
got
know,
a ways to go.
a plethora of errors, like, so medication errors. So uh, statistics around, like, how often they happen or, like, and how can patients double check, and push for that for themselves to double check they're getting the right medication, but they're getting the right dosage, which is probably a bigger and more common issue.
Yeah, medication errors are the most common mistake that happens in causing harm. As you said, we spend about $40 billion a year on medication errors in one form or the other. And so I think that knowing that as a patient and a patient's family member going in to advocate is just asking those questions. If that's a blood pressure pill for my dad, his blood pressure looks normal to me. Is it going to cause a problem if you give that medication? So, and I think you brought up a really good point. Medical harm is the third leading cause of death. That's been documented in the literature since 2013. What I want to say is I do have hope because, yes, it's an individual that makes a mistake, like Radondavat, the nurse that gave the vecuronium, the paralyzing agent, instead of Versed, the sedative, a couple
Mhm.
years ago.
Mm.
But when
Where was
you
I forget
really
where was
look,
that at? I remember this story. I don't
Vanderbilt,
and is it
yeah,
Vanderbilt? Yeah.
yeah. And the sad thing about the whole story is, I mean, anytime a medical professional makes an error, it's called second victim. They go around with this burden on their shoulders, even if it's harm and not death. That's pretty bad. We're all taught in the medical profession that we're the helping profession, and of course we are. But really diving into not blaming and pointing the finger because it makes someone feel good at okay, it was her, she's the reason she did it. But looking at the systems errors that are allowing a medication mistake that fatal, to happen.
Yeah. I mean, this goes back to the first, the thing that comes up to me is the Libby Zion case, from with serotonin syndrome that ended up leading to work hour regulations for residents because, she ended up getting just repetitively getting medications that on top of medications to ended up getting medications that were causing her symptoms to help stop her symptoms and that, the residents had been up. I can't remember if I remember they were like 48 and 72 hours at that
Oh
time
my
and
gosh.
were unable to, you're just,
Can't
now
function.
I think of it now, like, I mean, I'm old enough now, like, being up for 24 hours straight is, like, terrible. Like, it's like, I feel awful. Like, I can't back then you could do that stuff, but, yeah, so the Libby Zion case is the great example of that. I think was one of the first big cases like that. But,
Mhm.
okay, so, just to kind of double click on that. What do you think the biggest patients can do? Because I want to make this actionable as much as I can for our listeners. What do you think from a medication dosing standpoint? How do if you don't know your own dose, especially if you're sick and in the hospital, maybe you don't have an advocate there for you. How do you advocate for yourself, or as an advocate, how do you advocate for your family member to confirm dosing?
Well, nurses are taught the 5 rights of safe medication administration. So
Hmm.
the right patient, the right medication, the right dose, the right route, and the right time. And all of those things matter. And even just knowing that as a patient and a patient's family member is so helpful because you can say, that's not the dose that they were on yesterday. Or can you please double check and make sure, yesterday it was given by mouth and today you're giving it by IV or something like that. And again, it's just taking notes, and just keeping everybody aligned and on track and safe.
Yeah, I think one of the things that I try to relay to my patients in our wild health practice is if you're going to the hospital, just try to approach things from a curiosity standpoint, like instead of accusatory. Like it's more of like, oh, that's interesting. Why did that change? Or what happened there? Or, huh, I didn't know that was the dosing. And it's not to be passive aggressive, but it truly be curious because if you that kind of relays this feeling of curiosity to everybody as opposed to people being defensive. And um, when people are defensive, healthcare people are human. They're not using the part of their brain that helps them be problem solving and thinking. So, but as opposed to questioning from a curiosity standpoint, it helps people think in a different way.
You're right. Yeah, that's that part of polite that sometimes it's difficult when stress and anxiety is very
Totally.
high, either for the patient and their family or the healthcare providers themselves. So it works both ways, right?
Yeah, no, 100%. And like, I mean, I've been on both sides of the curtain like a lot, more than I want to be. But uh, I think as a healthcare provider, you usually like, if somebody like, if there's gonna be an error had and somebody and a patient or a patient advocate caught that, there is this, like, shame, and that's part of the cultural change that needs to happen in my mind. There's, like, this shame and, like and defensiveness that people have instead of that. So, like, when I used to teach residents, I would always, tell them to, like, be curious, not judgmental, like, it's the Ted Lasso. Um, but, so when you wrote, Surviving Your Hospital Stay, so what do you think if you were to think about that book, what's one story from your book that really kinda captures why this advice is so important?
The story I open with, and I teach it every time I teach nursing students because it's so powerful, is the story of Louis Blackman. He was a 15-year-old that had pectus excavatum surgery, came through the surgery just fine, but was a little dehydrated. They put him on Toradol or Ketorolac, which is contraindicated in low urine output states. The next day,
Mm,
he's having abdominal pain. It gets worse the next day. His belly's distended, and now he's tachycardic and, low blood pressure and signs of shock, which the team missed. Again, this was on a weekend that he was recovering and with residents, and they just were not connecting the dots, the nurses or the residents. And unfortunately, the night before he died, his heart rate was 147. By the morning time, they could not find a blood pressure. They tried 12 times with 7 different machines, and the last thing he said to his mother, "It's going black."
mm,
Cardiac arrested, couldn't revive him. On autopsy, they found 3 liters of blood in his abdomen
mm,
from the medication that caused, the ulcer that,
mm.
perforated. But he had signs for so long. Again, kids are resilient, we know.
Yeah.
Usually they've got the youth, no comorbidity, healthy until they fall off that cliff. And unfortunately, that was so sad because his mom's like, "Something's wrong with my son. Somebody help him," for several days before, his demise. So
Yeah, that's that's a terrible story. Um,
it is, and
yeah.
again, my mission to educate people to ask questions, to become empowered and learn
Mm,
about their health and try to be as healthy as possible. But yes, when we're in those situations, I have 30 stories in the book, and they're to help people in case they're in a similar situation that
mm,
they can say, "Oh, I remember reading the story. My grandma had a tube feeding, and the head of the bed should never be flat."
yeah.
And just relating those to potential situations they can find themselves in.
Yeah, it's hard, and I think it's gonna actually this is something I think AI is going to help a lot with, just medical knowledge. I don't I don't actually believe that medical knowledge is gonna be as valuable as it historically has been in the near future, but will be is the practical implementation of that knowledge, the soft skills, the ability to communicate to a patient, and then, help people practically implement whatever recommendation, in a way that's sustainable or tangible, for individual patients because looking at knowledge, like, knowledge is gonna be housed in other places and not in the human mind, uh, because you can now, like, put in a bunch of symptoms and come up with a, you know, accurate description of what could be going on with an individual patient, and that's only gonna get better. It's not gonna get worse. Um, but AI can't, use discernment. That's not something large language models, and do well. But discernment and that human part of communication is so important. So patients can use AI and advocates can use AI to be like, "Hey, this is what's going on," and come up with 5 to 10 questions to ask their providers, and providers are just gonna have to know that information is out there. You can't, like nowadays, like, patients will see their lab results way before the provider will, even in an emergency department. they can look and like refresh and they get uploaded before the provider's seeing another patient, and they're doing something else, and they come back in, they're like, yeah, I'm waiting for your labs to come back, and the patient's going to be like, no, they're already back, and they're like, oh, good to know. That all this information is going to be relayed in a way so rapid that providers are not going to be able to keep up with it. The skill where it comes from to being a provider is being able to listen to the patient and also make adjustments based off information, new information as it comes in, and also communicate with people. So I would encourage, like, now, I mean, this since your book has even come out, like, this has changed dramatically, right?
Mhm.
Around the use of AI, for patients, and have that help guide them to ask more questions.
Yeah,
Um,
I think it's fantastic. If you knew that your medication is a blood thinner, for
yeah,
example, then you could put in AI, what should I watch for? Signs and symptoms.
totally.
My husband is on a blood thinner for his atrial fibrillation and just fell down the basement stairs. Then we know the most critical thing we need to watch for is in neurological changes.
Right.
And I think that type of information is going to be really so critical for patients to take care of themselves as best they can and then raise the red flags of, hey, my husband's now confused or, his pupils are unequal or something.
Yeah. I mean, so, yeah, the stories that could be told there are sort of endless, but, so someone listening right now is about say they're about to go in the hospital, like, what's the single most important thing that they can do to protect themselves?
Well, one thing is research your hospital, like we talked about.
Yeah.
The other thing is to make sure when anyone comes in the room to wash their hands. The statistics that updated in 2023 was 1 in 31 patients every day acquires a healthcare acquired infection.
Mm.
So make sure everyone who comes in the room wash their hands. I mean, there's a lot of simple things that we could do. I know that if I were going for surgery, because we still have wrong site surgeries happen,
Yeah, which
is
is just
tox.
amazing. It's so
I know, right?
amazing. Like, how is that possible? But anyway, yeah.
It is, it's crazy. I believe that there's only 69% of hospital that use the WHO, surgical safety checklist. The
Oh,
others,
really?
it's not mandatory and they don't use it. So I'm thinking, why not? Mhm. Yeah.
Yeah.
Or, the surgical checklist that actually at the end of surgery, count the instruments, count the gauze sponges.
Mhm.
There's a woman a couple weeks ago that found they'd left a 6-inch retractor in her abdomen from
Oh,
the
a
surgery
retractor?
the week before. Yep, I
I
know,
mean,
that's not a small instrument.
a sponge I get, like, I've been in enough
Yeah,
surgeries, like, losing a sponge, like, sure, like, things get lost in there, but a retractor? That seems really challenging to do. Uh,
and the study a couple years ago said that 80% of those patients that returned to the hospital with a retained foreign body, 80% of them, their surgical checklist counts for instruments and gauze sponges was correct. Like,
yeah,
well,
yeah, yeah,
somebody's
yeah,
not really counting.
yeah.
But so, I guess I digress here. I was going to say, if you're going for surgery, make sure you have the conversation with that surgeon, because just even a couple weeks ago, there was a patient that had left knee surgery done that was supposed to have right knee surgery.
Oof.
So it would be marking the site,
Yeah,
specifically pointing out to the surgeon, "You're doing the surgery on this side, correct?"
yeah, that's really
So
interesting, like,
crazy.
I mean, it's amazing that still happens because I mean, 20 years ago, it was always you go in, you mark the site,
Right. With your
I know
signature, with your
I'm not
initials.
I mean, the only time I see surgeons now are usually orthopedic because I injured myself, but, um, yeah, it's just amazing to me that because it's always like, when I was even in medical school over 20 years ago now, like, you mark that site. Just can we digress before we jump down, like, ho what's the barrier to hospitals implementing, like I mean, I just assume at this point that every surgeon, you know, uh, especially orthopedic surgeons are marking the site every time. Is that not a is that not a requirement in any way? I would assume
I
it would
would think it would be, but what I understand from reading about the topic is that it is surgeon pushback. that it takes too much time and that they know what they're doing and that they don't make mistakes until they do. So again, we're humans. We're going to make mistakes. We get distracted by something and can think. I mean, I've heard of x-rays, being up there flipped, the
Sure.
wrong backwards. But yeah, it's
Yeah.
crazy.
Well, okay. Um, well, so your book is called "Surviving Your Hospital Stay: a Nurse Educator's Guide to Staying Safe and Living to Tell About It." Um, you recommend a free patient safety checklist. It's um, stan.store dot Dr. Julie, it's Julies, uh, IEMERS. So that's
Actually, I'll tell you a
from.
better place
Oh,
on my
okay, great.
website,
Okay, go for that, please.
drjuliesiemers.com. So drjuliesiemers.
Okay.
And then free patient safety checklist is on there as well.
Oh, great. Yeah, so I was looking at this stan.store, but that's great. Okay. Um, what other thing you wanna relay before we hop off?
Would say just become involved in your own health as best you can with understanding your diseases, your medications, etc. Becoming informed and becoming educated before a crisis hits, like finding that hospital that you're going to go to if you need to, making sure you have really good communication with your provider because that is so key to be able to communicate back and forth. And just, I've got hope. I think we really can turn this patient safety crisis around with awareness and education and informing and sharing and making this place safer for all of us.
Oh, that's great. Thanks so much for coming on the Wild Health Podcast. We appreciate it.
Thank you.
All right.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.